Okay, let's get started. A very warm hello to everyone joining us on Zoom for this webinar. It's 5 p.m. in Singapore on 21st October. On behalf of the SingHealth Duke-NUS Global Health Institute, I'm delighted to welcome all of you. This is our first part one of our three-part webinar series. And we will look at how healthcare innovations have responded to the COVID-19 pandemic and really look at what is going on in the region. As some of you might know, the Global Health Institute is focused on supporting and growing research and educational and capacity building collaborations in the region. We want to create opportunities to have productive knowledge exchanges and learn from each other. We want to make these exchanges systematic and strategic. And this is the rationale that underlines the objective of this webinar series. We want to highlight innovations that have been developed in Singapore and the region. We want to understand some of the challenges faced in developing them. And most importantly, we want to explore the potential to apply them in different contexts. We feel there's a richness of innovation across the region, which we have tried to tap into and bring you some key examples of, although of course there's a whole lot others that we can't showcase all of them. But we really look forward to a kind of lively cross-directional exchange of what's been happening in this space. I'm not going to say too much more because we have a whole session to discuss it. I'm going to hand over to our very capable moderator, Ms. Lee Chen Ee. Chen Ee is the Group Director, Organizational Transformation at SingHealth. She leads cluster-wide innovation projects to transform patient surveys. She works with stakeholders across the cluster to drive the innovation agenda and really kind of facilitate ground-up objectives. So she's ideally suited to moderate this session. We really kind of look forward to her moderation, and we thank her again for being here with us. Prior to her various SingHealth appointments, she also had positions with the Ministry of Health in Singapore, the National University Health System, Ministry of Finance, Ministry of Trade and Industry. So she knows, Singapore inside out, I think. She graduated summa cum laude from with an AB and MA from Princeton University, and I'm really kind of so happy to have her as well, our very distinguished panelists who she will be introducing. So I will hand over to her now, and Chen Ee, over to you.
Thanks so much, Amina. Thanks everybody for joining us today. We are very pleased to have a very distinguished panel here to talk about hospital-based innovations in the COVID era for this region. And I'm going to take a very short amount of time to introduce our panelists. They are, as I said, very distinguished, but I think all of you want to hear more about their innovations today. So very briefly, Prof. Derrick Chan is Head of Pediatric Neurology at the KK Women's and Children's Hospital. He's also Deputy Director for the SingHealth MedTech Office and Vice Chair Research for the Paediatrics ACP Research, and also is Research Director for KKH. Mr. Lim Sangva is the co-founder of Arrowdot, and he is an electronics engineer with a dream of seeing his own country, Cambodia, develop its own products in consumer electronics, Internet of Things, and automation systems. So his company provides solutions to local companies in Cambodia who need support on system designs with both hardware and software. Professor Ngiam Yuan is the Group Chief Technology Officer at the National University Health System. He oversees technology deployment for the Western Healthcare Cluster of Singapore. He's also Associate Professor for the Department of Surgery at the Yong Loo Lin School of Medicine at NUS. He is also Chief Advisor to the Center for Innovation in Healthcare in NUHS and Deputy CMIO. Assistant Professor Daniel Ting is a consultant vitreoretinal surgeon in the Singapore National Eye Centre. He's Head of AI and Digital Innovation in SERI, the Singapore Eye Research Institute, and Assistant Professor in Ophthalmology with Duke-NUS Medical School. He's a prolific writer and publisher of many journal articles, and also Associate Editor of Nature Digital Medicine and Section Editor of AI and Big Data in the British Journal of Ophthalmology. Dr. Rena Dharmawan is Associate Consultant and Surgeon at the Department of Head and Neck Surgery at the National Cancer Centre, Singapore, and Clinical Entrepreneur in Residence at the Centre of Technology and Development at Duke-NUS Medical School. Rena is a serial entrepreneur and co-founder of 3 Singapore-based MedTech and Health Tech startups, Privy Medical, Jagami, and Advark Labs and Catalyst. Professor Chert Chai from Thailand is the Vice Hospital Director and Assistant Dean in Quality Development at the first and biggest hospital in the country with 2,200 beds, that's Siriraj Hospital in Bangkok, with more than 8 years in quality improvement experience. So with that, we are going to invite our panelists to give a mini presentation on each of the innovations, 1 to 2 minutes each. We'll start with Derrick.
Okay, great. So I'm Derrick Chan. Thank you, Chen Ee, for the wonderful introduction, and thanks to the GHI team for organizing this. So I'm just going to talk 1 or 2 minutes about SG Inspire. You know, I don't need to say the COVID crisis. Everybody's fully aware of the COVID situation. But back in March, when this all started out, and we were hearing about what was going on in Italy and Europe, and it was such a concern over the shortages, we felt we had to do something. So a group of us from SingHealth clinicians actually got together, and there's respiratory physicians, intensivists, and technologists and clinical engineers. We all got together basically and put our minds to this and essentially put together what were the clinical criteria that we really needed for a ventilator that would support us should the situation turn bad for Singapore. And together, we basically put together the specifications and then developed the kind of the plan for what we were going to do, and essentially started to put together the devices. And it was a very unique situation because you'll remember that back then everything was shutting down, especially in China. So there was a real supply crunch, and we actually had to adopt what we coined a supply to design approach. Basically, we needed to look at what we could access in order to produce these devices should the occasion arise. And it required a lot of ingenuity, a lot of long hours and hard work to put this project together. But it also essentially needed to position itself to bridge the gap between the high-end conventional ventilators, which were in very short supply and very expensive, and the very, very basic designs which have no essential functions. And so some of the things we needed to make sure that the clinicians had, if they were to use this, were things like breathing triggered support, the ability to have an interface which was user-friendly. We knew that in a resource-limited setting that there might not be access to high-pressure gases, which conventional ventilators need. We also knew that certain things like fully trained intensive care staff might be in extremely short supply. So all of the design features were tailored to try to make those considerations not an obstacle, essentially, to implement this. And so we came up with this, and I've got to say that we had a remarkably agile response from our academic medicine side. The grant funding, the response was incredible to basically make this project possible. And essentially bring it to the stage that it got to, which was advanced prototype, and we're moving into the final stages as we speak. Thanks very much.
Thanks, Derrick. Could we have the next slide, please? Okay, thank you. Could we have Sangva introduce your innovation? Thanks so much.
Yes, thank you, and thanks, Derrick, that indicate about the usefulness and the technology behind the ventilator comparing to the typical ones. So it prepare for the pandemic of the COVID-19, as I saw many teams in different countries are researching and developing this low-cost ventilator, and Cambodia engineer also taking one part to develop this type of ventilator as well. So my team as an Arrowdot local engineering team who work on IoT and automation solution and product development. So we come up with the emergency low-cost ventilator as well, which we developed in the price range of $200. When we see of this ventilator on the right side, so we try to minimize and make it portable for moving the ventilator across different area and inside the clinic or any health center as well. So as we see this, it has the function of manual and automatic regulated on the three main factors of the ventilator, as we also seen in the typical one, but the typical one is more modern and precision, but we try to make it a useful ventilator and accurate comparing to the typical one as well. And we also have the opportunity to test with our University of Health and Science in Phnom Penh to modify and adjust in some parameter to make sure it can be used with human during the pandemic. As we have seen, Cambodia is a country that lack of the ventilator as well. So we only have 300 ventilator device across the country, and it's only available in the capital of Phnom Penh, and mostly in the rural area. In the health center, there are very much lack of the ventilator. And by using this technology in the future, even the COVID-19 ends, we still need this type of ventilator to supply to the health center in the rural areas that are lack of this type of ventilator. And my team still want to encourage the local and foreign engineering to work together in order to develop this to make it more functional and useful for the ventilator needed. Yes, thank you.
Thanks very much, Sangva. Now we'll go to Bot MD, and which has been working very closely with NUHS and Professor Ngiam. Would you like to talk a bit more about this?
Thank you, Chen Ee. So I have the pleasure of presenting one of the initiatives that we've had, which is to use a chatbot to help our COVID patients, especially in the dormitory setting. It was actually quite serendipitous, as in we actually initiated this program to work with a company, Bot MD, who couldn't join us today, but I will kind of speak about our experience. So last year, actually late last year, we started a project to see how we can provide timely information to our clinicians using a chat interface. So as you know, a chat interface is essentially what you would see on your messaging applications, be it WhatsApp, WeChat, any of the chatting platforms, except that now you're talking to a bot. So it was late last year, and we were going to launch it early this year in January when COVID hit. And somewhere within the month or so, some of our colleagues my colleagues in NUHS were really passionate about transforming the use of a Bot MD to a patient-facing bot, such that it was called a COVID-19 Bot MD, such that migrant workers could use it to undertake certain functions, such as keying in their vital signs and to chat with doctors to see if they needed to come in to be seen. So it was really quite serendipitous and timely that we had the opportunity to test and then deploy a chatbot. And I would say that it has saved us a lot of so-called unnecessary effort that would have been taken, i.e. manually going to pick up patients' vital signs had we not had this chatbot. So I think there were a number of initiatives around the island when COVID hit, and I just wanted to share that our experience with it was that, deploying chatbots might seem like an easy thing, but actually there were quite a number of technical challenges that we had to overcome, notwithstanding things like cybersecurity as well. So I'm happy to hear from others in the panel what their experience was. Thank you.
Thanks, Ngiam. Okay, now we'll go to Assistant Professor Daniel Ting. Dan, would you like to share?
Thanks, Chen Ee. Hi, everyone. It's Daniel here. Thanks for the kind invitation to share. So, I mean, Dr. COVID is something that we have jointly developed in SingHealth with A*STAR and advised by IHIS. And really, I mean, just before I go into Dr. COVID, and I just wanted to share the rationale and the background why we have actually developed this at the very first during the initial phase. So I mean, the few questions that really was troubling us when we set up the CCF was the number one question is, how can we reduce the dwell time and the exposure risk for all the healthcare workers, within the SingHealth settings, and how can we actually manage 3,000 patients at one time in Expo? So just to give you some figures here, I mean, we have about 15 doctors during the day shift and 6 doctors during the night shift. And that actually really brings down the doctors to patients ratios to 1 to 400. So how do we actually manage that? And then the third question that we wanted to also address is, how can we communicate with these migrant workers where they are actually suffering from the language barriers, the illiteracy issues, and more than 50% of them do not actually speak or understand English. And psychosocial well-being for someone who being kept and managed in the expo hall without knowing where they are is also another clinical challenge that we wanted to do. And so jointly, we have actually thought of digital solutions called the Dr. COVID, which is a multilingual AI-enabled virtual system for digital monitoring of these patients. And I would also like to acknowledge my team is co-led by Chen Ee, who is also the moderator today, and also supported by the medical director, Professor Tan Hyang Kun, advised by Professor Kenneth Quek, and Mr. Steve Lee from IHIS, who is the Deputy CE for IHIS. And on the ground, we were also widely supported by the IT, operation, adoption team, communications, clinical nursing, and psychosocial leads as well. So what these Dr. COVID is, we actually broadly divided the Dr. COVID development to 3 different phases. So we have a total of 3,800 users who have actually used it, by the end of it. And it's a Telegram-based digital solutions where we actually disseminate different medical nursing administrative messages in 5 different languages. And for example, we actually send out the reminders for vital signs entry, video clips with inspirational messages, and also some social wellness messages as well. And to date, we have also disseminated about close to 900,000 messages through this platform. The second phase was to really perform some surveillance system on the mental wellness and the clinical progress monitoring of the migrant workers, and 98% of them felt that it is a very useful digital solutions. More than 96% of them said that they're actually coping well, they're happy, they're not anxious, they're satisfied, and 86% of them felt that they're being cared through this platform as well. The phase 3 AI chatbot, that is a deep learning on NLP-based chatbot, we actually managed to complete it, but then we did not manage to deploy it because of the closure of CCF. But having said that, right now, the second the phase of this project is to pivot some of the back-end technologies back to the SGH campus to actually serve a wider community within the campus. Thanks very much for sharing.
Thanks very much, Dan. Now we go to Dr. Rena Dharmawan. Rena, would you like to share with us about SwapBot?
Hi, thanks for having me. Well, the story behind SwapBot was that us specialists, head and neck surgeons, ENT, anesthetists were sent to the front lines to do the nasopharyngeal swabs when COVID just started. And obviously when that happened, a bunch of us kind of thought like, hey, it'll be great to automate it. And it'll be great to actually have something that, for example, when we go and do an eye check, right? When you go and see the optometrist, you plant your head into this machine and then your nose swab was actually done. So we partnered with BioBot Surgical, who is a local MedTech startup here. And I have to give it to them actually with this. I mean, after brainstorming, in 6 weeks, they actually came up with this first prototype with us. And we did a clinical trial in SGH and BVH. So what are the benefits of SwapBot? What we believe one is obviously is to reduce the exposure of healthcare workers and people in general to patients who are potentially COVID positive. For it also reduces manpower. These healthcare workers who are supposed to be doing swabbing can be used to do other more important clinical work. Number 2 is that there's some form of standard and quality, standardizes the quality of all nasopharyngeal nasopharyngeal swabs. So we have a green light there. So if you have a green light, it shows that actually the nose swab has actually entered at least 8 centimeters into your nasopharyngeal space. So there's some form of quality barrier there. Obviously, if a robot is tireless, I mean, all of us have, most of us have done swabbing duties, and I think after 2-3 hours in the PPE, we all get really checked out. So the robot is tireless, it can go on for 24 hours. From our study, we've actually shown that it is much more comfortable than swabbing done by humans, and that's statistically significant. And it's safe because it's calibrated according to a microsurgeon's touch, and there's a few safety measures that we put in. So we launched it last month, and I mean now we're in the talks with MOH, Changi, Raffles Medical to actually try to do it, and it helps mainly with the mass swabbing operations.
Thanks very much, Rena. And now we'll go to Professor Chet Chai, who's going to share with us the 5G driverless vehicle. Professor Chet Chai, are you able to unmute yourself?
Can you see my slides?
Yes.
Okay. Good evening, everybody. So I just want to present about the 5G AI unmanned car. Okay. So this is the project that's based on the support from the government, as the National 5G Committee agreed to support the project of the 5G for smart hospital. This is the unmanned car for delivery medication and medical supply is one of the 9 projects that we are going to moving on for 5G for smart hospital. The 5G unmanned car towards smart hospital is the additional to the project that we work collaboratively with industrial engineer at Mahidol University to make it a central supply management. We study with closely to see what is the best route for using the central supply as efficiently as possible. And we come up with support from the Huawei and also the Neolink to give us the trial of the unmanned vehicle. So this unmanned car, they don't need the driver, but they can go by themselves. And we're going to plan for using this car for deliver the medication and medical supply. So at this stage, we do a trial route and check out the 5G signal to make sure that it's very strong signal to control the unmanned vehicle. And we plan to launch this, implement this in real world within 3 to 6 months. And actually, we plan for 5G AI pharmacy inventory optimization using the AI to predict the number or the amount of medication and medical supply that we need. This is the result, the preliminary result that we used the 12 million record of the medication to predict using the characteristic parameter of what is the doctor name that see the patient today, what kind of clinic, the number of patients that we plan, we expect to see, which medication that they already given in the past visit. So all these parameters, we predict the number of the amount of medication that we have to provide to the patient. For example, the metformin, aspirin, and the preliminary result showing that the accuracy to predict the next 7 days of medication that we're gonna use is mean error is about 5%. So that means we can use this type of algorithm combined with the central logistic with unmanned vehicle. We expect to decrease the inventory to 48% to 70% in the best case scenario in our model analysis. So because if this can happen, we're gonna decrease the cost of inventory. I think it's gonna be like 100 and 200 million baht per year. Thank you.
Thank you very much, Professor Churchai. So I have not seen any questions yet come in. We're going to go now into the Q&A section. So for all the participants, please feel free to put in your questions, and I'm going to start this off by asking some questions of my own. Maybe if I could start with Derrick. So Derrick, I would like to ask about SG Inspire. How did that compare? How does that compare in terms of cost with higher cost ventilators? I know you talked about finding that sweet spot in terms of functions.
Yep.
What was that trade-off like in terms of functions and cost for you?
Yeah, so I guess a conventional ventilator, you know, they cost like $40,000-$50,000 upwards. So they're really not cheap. They're complicated, so you need to be trained to use them. And then they require certain things like high pressure, oxygen, gases. They need certain electrical, stability. So they're kind of very niche, very high-end products. At the other end of the scale, a lot of what we were seeing were open source ventilators. I mean, I think everybody was just trying to be helpful. A lot of it was they're very simple and kind of deliver a fixed breath. Whatever you set, it delivers. And when we talked to our clinicians, we realized that wasn't quite what was suitable for the patients that we were thinking of. The system we designed, essentially, certainly it's more expensive than Sangva's system. I'm not going to compete with you on that one. Certainly it's more expensive. That it's in the order of like, thousands of dollars, like with less than 10,000, we think. And of course, because it's a question of scale, where if you produce more, then they get cheaper, right? But it's of the order of thousands. And the emphasis for us was a balance between, that price point, but also to make sure that there was the safety, that there was the rigor in the design. It's got features which, some of the features with the conventional ventilator has, which is like sensors. So it triggers, it synchronizes with breathing, which is really important because not only does it not fight the patient, but when you want to wean the patient off the ventilator, that's when you need it to kind of reduce its support. And those are key things that our clinician group emphasized very strongly were necessary. And then we did a lot of testing, kind of bench testing, animal testing to make sure that it's robust. And we found a lot of important information and know-how, which you can't find just from bench testing alone. And together that I think has made it a very robust and safe device. Our intensivists reckon that, your average intensive care patient, probably 50% of them can use this device. So that's not bad. We don't intend to kind of like, match the conventional ventilator for the really, really sick patients, but I think it's pretty good that it can do that.
Great. Thanks for sharing, Derrick. I'm going to go to Sangva next. And Sangva, I was really impressed by the price point of your ventilator, of course. And I was struck by the fact that that your group came up with, and I know there are many other groups within the region which have come up with, I guess, similar innovations to meet the common problem statements. I wanted to ask you, as well as Professor Churchai, and others on the panel as well, what do you think is the potential for us of innovators across the region coming together to solve similar problem statements?
Yes, this is a good question, and it is a things that we need to do together, not only in Cambodia, not only in Singapore. And at the beginning of the start of pandemic across the world, so as a Cambodia team, we also work with and share about our source code and our electronic designs to the Malaysian team from the from Ganes Mures, and the team is now has a big support from their government and especially Ministry of Health, and they are shown to public very famous now about their Arrowdot ventilator. And it is a thing that we can share, and what we have discovered, what the resource that we can make it in a very low cost. And so we can share the design, and then we need to work together with the other ASEAN country or across the world to develop it in more efficient way. And in terms of quality, it's a must to make sure, like Dr. Derrick, that it need to be to synchronize with the in and out exhale of the patient breath, so to make sure that it's not make them too uncomfortably breathing, and it affects with their health also. Yes.
Thanks very much, Sangva. And would like to ask whether Professor Chet Chai has any comments on the question of whether innovators across the different countries in the region can come together to solve some of these common problem statements.
Yes, in my perspective, I do believe that co-learning, co-collaboration, and co-creation together is more powerful than we just create by ourselves, because the same problem, we can have the different perspective to solve this problem. When we create a new thing that we can distribute or generalize to other area or other country, that is more efficient and more productive. So I think it's very good opportunity that we can join together, and then we can co-creation together.
Thanks very much, Professor Chet Chai. I'm just looking at some of the questions in the chat, and I think I'm going to ask, first of all, Rena to respond to some of the questions on Chatbot. There are a number of questions here, such as whether the Chatbot has auto-sterilization ability, or whether one has to manually sterilize this. I know the answer to this, I'll let you answer it. And then there's the question on the level of accuracy and how long it takes to do a swab for a patient. Rena, would you like to answer?
Yeah, thanks for the question. So, so to ask about the sterilization, as of now, no, it doesn't auto sterilize, but there, we do have so the thing that is patient engaging and touches the patient is literally the nose piece, and that nose piece that goes into the nose is disposable together with a drape that covers the top part of the machine. So after the disposal of the disposable components, which is nose piece and the drapes, the person, the operator has to then wipe down, take out the swab, obviously, send it for a test, and then wipe down the entire robot. I mean, in the ideal, and we did give the challenge to BioBot that if they could come up with something that auto sterilizes, I think that would be amazing. But for our first gen that we have launched, no, the answer is no. How long does it, what's the level of accuracy? Do you mean the location, the anatomy location, or in terms, okay, if you're asking about in terms of sensitivity, specificity, and negative predictive value, the negative predictive values and the specificity is high. The trouble that we had with the clinical trial that we ran in SGH and BVH was to really identify the patients who are acutely positive still with ARI symptoms to calculate a very more accurate sensitivity. The trouble was the patients that we recruited was more than 3 weeks post symptoms. So we still are continuing clinical trial efforts to basically try to get a more accurate results. How long does it take to do the swab? Is about 20 seconds, 10 seconds per nose, basically. Yeah, I hope that answers.
Thanks, Rena. Can I ask also, what is the team's plan for deploying this in the region outside of Singapore? And you could also speak about regulatory requirements. I think that's one of the questions in the chat, whether there are any form of harmonized regulatory requirements. Obviously, I think there are different regulatory requirements for different devices and so on.
I think the regulatory requirements still depends on the country. For Singapore, they classified SwapBot as a Class A device, and so we have gotten HSA notification for that. How are we? We are the BioBot, who are a commercial entity, is doing. Is in the talks with the region, Malaysia and Indonesia specifically, to try it out there. But my hope is that we will actually deploy it here within Singapore first. So yeah.
So I've got a quick question for some of the panelists who are building medical devices in COVID times. As we all know that the medical devices typically have a regulatory pathway. So I just wanted to canvass the views of the few speakers who have just mentioned about rapid prototyping and how long it took for them to launch their devices. Yeah, maybe you can share your experiences in overcoming some of these requirements. Can start Rena since she's down.
Okay. Okay. For the regulatory I mentioned before, we are classified as Class A. So what we had with HSA was a notification before we could actually commercialize. So that part. For the rapid prototyping, to be honest, I'm pretty impressed with our engineering, the engineers from BioBot. It was literally, I'm trained biodesign, right? So to me, this project was perfect because it was a lot of brainstorming and really good collaboration with the engineers, going back and forth. Once they had a prototype, we tested it. They went back to the lab again to basically retry it. So it was a great experience working there. I mean, obviously on the backdrop, what I'm really impressed. I mean, we took 4 months from idea to market, and it's very impressive that all the administrative and the paperwork that obviously everybody, I mean, all of us who are in MedTech involved, from the agreements to the patent filing, it's fantastic that that we managed to get all these stuff sorted within this short period of time, and yeah. And that's why I mean, I don't know if it's good to say it now. I always tell Chen Ee, like, it is possible. It's fantastic that it is possible.
Yes, thanks very much, Rena, for sharing. Derrick, you want to comment on Ngiam's question about the regulatory obstacles and how you managed to leapfrog? I know you were frustrated at some point.
Oh, well, I think, I'll be honest, actually, HSA was really quite collaborative in a lot of ways. Like they were trying to, I think, move to accommodate, because I think this has been a very unusual situation all around, and I think they did kind of move quite quickly to try to put the provisional pathways in place. I mean, I would say that some of the obstacles are sometimes it's just some of the requirements might not be so obvious. And certainly I was very blessed that we had our medical technology office team, because clinical engineers actually know a lot of the requirements, the dossiers and stuff like that. The ISO 13485, all of this kind of stuff may seem very bureaucratic, but you know, it's part of the quality control. But it's very fortunate that we have people like that who know a lot of this stuff, and they were trying. The difficulties, I think, perhaps are less of an issue with the regulators per se, because I think they were trying. But from our side, it's sometimes I guess the relationships, in the sense that, I mean, SingHealth's not a manufacturer. We're not a company. We can't make stuff. So actually, it's interesting that you know, a lot of this HSA stuff actually carries certain I guess, ramifications or implications. If you do it yourself, then it means you take on all of the responsibility. So that aspect, I think, is something which was a learning point for ourselves. And actually, you know, we would deploy it in SingHealth, but the kind of that last step, the HSA part, actually you need your industry partner to take it over and run with that. So it's really cool to see Rena's kind of project up and running. When she was describing the swabs, I just could imagine them all sweating through their PPE in the scrubs and the swabs. I felt really, really sympathetic to all of them.
Thanks for sharing, Derrick. Ngiam, I'm going to turn it back to you. And I think there are a bunch of questions in the chat for both you and Daniel on the chatbots. So there are a few questions here for maybe Ngiam first. The question here is, how does the chatbot reduce the need to get vital signs in person? And then for Daniel, first of all, can you elaborate a bit more on how Dr. COVID monitors mental wellness? What were some of the indicators used to measure this? And also, how does it monitor for clinical progress? Are these subjective or objective measures? Are the apps paired with any monitoring sensors? Okay, so Ngiam first and then Daniel next.
Right, thanks. Since we're on the topic of chatbots, I think a little bit of background is at hand. Right? So these chatbots are essentially AI tools. The ones that we've previously deployed on the COVID situation, they were actually largely rule-based robots. Right, they only can take a certain kind of input. The kind of variation they can accept is very minimal. But that served the needs of the time, which is we needed to be able to collect symptoms, so not just vital signs, but symptoms as well as self-measured vital signs from the dorm 24/7 a day, 24/7, right? So to send people in, say like 9 p.m. to take vital signs from everybody, it's going to be quite a massive undertaking in the dorm setting. And remembering that some of our dorms had 10,000 people, so it was going to be a very big effort. But really the idea behind taking vitals is to spot early deteriorators. So indeed, in the so many thousands of people that have signed up, right, we actually managed to pick up quite a number of patients who were young and yet they had low oxygen saturations, and we were able to bring them into hospital early, and indeed they developed the COVID-19 ARDS type symptoms. So I think that really is the proof of the pudding, right? Which is you deploy a digital health app to have a clinical impact directly on patients. And not just on patients, but administratively, the number of people we have to deploy on the ground to actually monitor those vital signs, it's a small, tiny fraction of what we would have needed to have done so. So I think we were quite lucky to have had such a platform to help us manage our patients in the dormitories. And I'm just going to pass over to Daniel and to corroborate and see if you had the same kind of experience.
Thanks, Yang. Yeah, I can't agree more, because some of the very initial reasons why we started building this chatbot is totally for the same reasons. Like, how do we actually use, leverage and harness the digital platform to remind the migrant workers to key in the vital signs, and that's really to spot those the ones who are actually going to deteriorate, like to spot the early signs for those who are likely to deteriorate. And I would probably also share a bit more on the both the clinical and the mental, the well-being piece. And so the mental well-being piece, there's also another questions about how, what are the indicators, just along these lines as well. And when we actually look at the validated mental well-being piece, I actually looked through the public domain, and with the intention to choose the simplest ones to do it, just because of the earlier reason that I mentioned, because a lot of them do not understand English, and a lot of the validated questions that even on the public domain is not very generalizable to the patients from Bangladesh or from from the other parts of the world. Is mainly very wide population driven. So how could we actually generalize these questions to answer them? So to me, I say the simpler it is, the better, because we just wanted to make sure that these guys are not frustrated, they're not getting very agitated. That's why we actually only asked them 4 questions. So it was the 4 question was, were you happy yesterday? And were you anxious yesterday? And were you satisfied with your life? Okay. And then and what do I do in my life in Singapore is worthwhile. Okay, the last question is a bit irrelevant, but then we still ask that just because we wanted to use a validated questionnaires, just in case you wanted to also publish such results in the public domain. And we understand that we do not want to create any unnecessary workloads for the psychologists on the ground, but at the same time, we want to identify those who are at very high risk of, falling into troubles. So, I mean, we set the threshold very high for those who wanted to actually be identified, to be identified to get help from us. So, I mean, for those who actually answer, you know, the one that actually score like the yes for all 4 questions, then we get the psychologists on the ground to actually reach out to them to make sure that they are mentally stable, they are actually okay. For clinical well-being, I mean, we actually also, again, the same broad principle applies as well, to keep it as simple as possible, but to identify those with, say, chest pain, shortness of breath, and also the calf pain. So those are the 3 main questions that we actually, after consulting with different experts within the campus, they thought these are the 3 main questions that we should actually identify, and then to actually, you know, fish them out to actually examine them. Yeah. So those are a few things, both from the clinical and the well-being piece as well. Yeah.
So I'm going to ask about non-COVID use cases. And I know for Bot MD, Ngiam, you are trying this out for diabetes management, chronic disease. Maybe I can have both Ngiam and Daniel talk about this in turn.
Yeah, okay. So just a very quick point about this, right? So chatbot technologies have still some way to develop before they can be truly conversational. At this point, the bots that we have are, you know, are capable of at most complex branching logic. Some are capable of sentiment. This is really the final frontier when it comes to chatbots, right? So we are actively pursuing conversational level chatbots. And this is vitally important because you want to have a very, very smooth experience, conversational experience with your target audience. So we've had a fair amount of experience with the internal facing chatbot that BotMD has developed with us. So that is facing our doctors and our researchers to be able to access hospital content and things like rosters and things like that, useful things, right? But when you want to expose chatbots to patients, one has to be extremely thorough in the way you test your bot, because, you know, one poor experience and very few people want to use your chatbot, right? And you see that as an encumbrance. So I think it's in terms of developing it for patient use, we are taking steps to ensure that the bot delivers a consistent conversational experience, and that therein we will empower the bot to be able to do more for our patients without needing to, say, visit a hospital, for example. So that's where we are going with this. Thank you.
So Ngiam actually brought a very interesting point. How do we validate the chatbot's performance? Because it's something that I've actually trying very hard to search in the literature. How can we, because, you know, I personally do a lot of the AI deep learning type projects, and the chatbot itself is something that I still struggle a lot with to actually find a very robust statistical manner to actually validate some of the chatbot. So do you actually do a simulated, you know, the questions using, say, 10 experts to, you know, to validate the response? Because for the speech to text chatbot, we know we can actually use the text as the reference standard to validate the speech to text, you know, the translations. But to the text to text, you know, the statistical analysis, I'm just wondering whether, you know, Ngiam, whether you could actually share a bit more insights in terms of how do you guys validate the accuracy of the conversational chatbot? Yeah.
Okay, so I think there are 2 parts to what you just described. So first part, you're mentioning something called ASR, right? So automated speech recognition. So that is now actually largely solved kind of problem, but for the fact that we have Singlish. So Singlish is the bugbear. So you speak standard American or British English, most you know, Google Assistant, Alexa could probably get up to about 80-90% accuracy in terms of ASR transcriptions. Just that we speak with a Singaporean or multiracial kind of accent. The same English can be coined in 20 different forms, right? So that's where some work we have with NUHS is being undertaken to further improve the local language corpus for the ASR part. And you're absolutely right, that feeds into the chatbot, right? So we're not going to build a separate ASR voice-based chatbot model. It will be fed into the same text-based chatbot. So as for the text-based chatbot, you're referring to how do we evaluate the performance of the chatbot, right? So we use 3 matrices, and these are really very computer science driven kind of matrices, right? So for conversational content, we look at sentiment, so sentiment appropriateness from one to the other, and also things like coherence as well as content appropriateness. Yeah, that's how we measure it.
Right, and the right will be the clinicians to actually assess these appropriate.
That's right.
All right, thanks so much. Very interesting conversation about the chatbots. I'm going to, bearing in mind that we are also looking at how we can deploy these innovations to developing countries. I want to ask a question of Sangva and Chai. What do you think are the key success factors for an innovation that's coming out of Singapore to be deployed in Cambodia or Thailand, or even for Ngiam, right? I know BotMD, I know you're not a representative of BotMD, but I think some of the innovations Dot had shared with us are also being considered for places like Philippines and so on. Wonder if each of you can just make some very quick comments on the key success factors for us, an innovation that comes out of Singapore to be deployed to one of our regional countries, regional neighbors.
Yes, I'm Dr. Chai. I would like to respond to this. I think the key of the innovation is create new value to the customer. So that means the innovation that's successfully implemented in one country, it doesn't guarantee that it's going to be successfully implemented in other country, because the value and also the pain or different context may not be the same. And so the key success is you have to empathize on different contexts to make sure that your innovation that serves their need and their value. So that for me is a key. It's a value driven. It's not a technology driven to the customer. That's
very insightful indeed. Thank you, Professor Chai. Sangva, would you like to comment?
Yes, from my point of view, it's from our experience that the way that we share our technology, the way that we share our research is an important sector through a technology hub that they link together with, for example, the Malaysian team that I mentioned earlier, that we have a technology hub that has a communication between both countries. So if we can create a collaboration hub of research technology team that whenever the crisis or any emergency solution is needed, so the hub is take an important role to communicate between the hardware team from Cambodia, Singapore, Thailand, Vietnam, across different regions to work together in solving this problem. Currently, nowadays, we see whenever there is a problem, each country is working differently, and some technology are being shared, some team are not receiving those technology and living under the pressure condition. Like South Sudan, as we've seen, the ventilator is only 4. We have only 4 ventilators across 12 million people. So it means that one ventilator is supplied to around 4 million already. So how can we survive to this pandemic? So it needs to be a shared community of technology to work differently. And when one country can develop, possible to develop as much as possible, we can share that device to other countries also with an NGO price or whether affordable that to those countries. Yes.
Thanks very much, Sangva. Ngiam, any comments from you? For some reason, I'm not seeing Ngiam on my screen now.
I think maybe in trying to get off mute, he put himself off. But I'll just jump in. I'm sure he's logging back on, but I'll jump in because I just, when Sangva, what you said was just like lit up, my ears and my mind and, everything else. So that is certainly something, we at the Global Health Institute would like to encourage and facilitate because that's one of our key kind of roles. So we can maybe continue a conversation, later on. And that's something I wanted to kind of reach out to all the panelists, but you kind of accelerated that thought in my head. And it is something that we would really look forward to working very closely on, both specific ideas and then, like you mentioned, more general kind of infrastructural positioning. So yes, please, let's continue the conversation. And okay, Ngiam is back on.
I'm sorry, I'm not sure why I got cut off. Just a quick comment and not specific just to Board MD's deployment elsewhere. The point is that if you make your technology quite generalizable and overcoming regulatory barriers, which is something that I felt was very important, then the chances of it being deployed internationally is much higher. So just to take a chatbot as an example, provided that you stick within the country's privacy regulations, a chatbot can be global, right? There's nothing to stop somebody from using a chatbot in Philippines or Indonesia, as long as your chatbot is able to deliver a delightful experience, right? If your chatbot is smart enough, it can deliver contextually aware responses to the users. I don't see how, I don't see why it cannot be generalized to other countries easily. Yeah.
Great, thanks Ngiam. So I'm just mindful of time. It's 5:56 p.m. right now, and I've promised Amina to hand this back to her. If I may just summarize, I think some of the insights from our panelists in terms of scaling and scaling effective innovations, both in whichever country you started at, and also going further abroad. Some of the comments that were made were that a good team is essential, collaboration is essential with a team of not just the people who are actually working on the product, clinicians and engineers, but also with regulators, with hospital administrators, even communications folks. And I think, as Professor Churchai said, we have to focus on creating value and empathizing with the people who are actually going to use it. I think Rena talked about, looking at that patient experience, whether it's safe, whether it's comfortable. So I think Sangva also mentioned the part about the price point and how we want to look at something that's appropriate in terms of price point and being sensitive to the cost that our consumers can bear. And I think looking at the whole context as Ngiam said, being very aware of the context that we implement an innovation in, and certainly a chatbot where we use AI, that would be something that would be very important for us to take into account. So with that, I just want to thank all our panelists for taking the time to share with us their latest and greatest innovations, and wish them all the best for pushing these ahead. Thanks very much. And over to you, Amina.
So at this point, I just also want to add my thanks to all the panelists. It's really been very interesting to hear all your work, and we'll continue to follow the progress as you roll it out, both in Singapore and in the other countries. And maybe we will have an opportunity to, try to see what kind of cross collaborations we can develop with these specific ones as well as more other ones. So please, let's keep in touch. That's kind of really, it's the idea is not just to have this 1 hour discussion, but really to to start some kind of relationship. And then, of course, I also want to add my thanks to Chen Ee for moderating the session. And thank you so much for taking that time and kind of bringing your expertise in the innovation area in Singapore to this discussion. I learned a lot. And even though I'd been kind of reading about this before, it was great to kind of actually hear it from the people who developed it. And then to the audience, thank you for being here with us. And do look out for next week, same time, same place. We'll be having at 5 p.m. On 28th October. And that week, we look at more community-based healthcare innovations. Again, we've got a range of panelists from both Singapore and the region. So I look forward to that discussion too. Please sign up, and good night. Have a good day.
Thanks, Amina. Thanks, Chen Ee.
Everyone.
Thanks, guys. Thanks for the invitation.
Thank you.
Bye.
Thank you. Bye-bye.
Bye.